We're not going to run rapid fire through 4 different endocrine neoplasias associated with the GI tract. None of these is particularly high yield, but there are some easy associations that you should memorize. Glucagonomas, for example, are exactly what they sound like. They're pancreatic tumors that secrete glucagon. Now, what would you expect the effects of excess glucagon to be like? In a glucagon-secreting tumor, you'd expect hyperglycemia, hyperlipidemia, and all the complications that come with excess glucagon. In short, pretty much like diabetes mellitus, and it makes sense that a glucagon overload presents like an insulin deficiency. Funnily enough, the diabetes is not always that dramatic, nor is it even the most common symptom. The main symptom that you have to remember about is the horrible skin condition that glucagonomas cause, necrolytic migratory erythema. It's basically exactly what it sounds like, painful erythematous lesions that spread, become necrotic, and then slough off. It's not life-threatening, but it definitely sounds awful. The combination of new-onset diabetes and a migrating skin rash should leave you no doubt that you're dealing with a glucagonoma. But there's a couple of other symptoms that are associated if you feel like memorizing something extra. Insulinomas are a lot more intuitive than glucagonomas, so tell me, what do these tumors do? These ones make a lot more sense. They're beta cell tumors that present with new-onset hypoglycemia. Now, we didn't really get a chance to talk about this, but hypoglycemia isn't as rigidly defined as hyperglycemia. The lower end of normal for a random glucose is around 70, but you don't really call it hypoglycemia until it's either really severely depressed, or, more commonly, you start to experience symptoms. Now, the symptoms generally occur in 2 phases. First, the body has a minor panic attack around 50 mg per deciliter of glucose, and kicks up pretty much all the catabolic hormones it can. Which hormones am I talking about? Well, you got your glucagon, cortisol, growth hormone, but the one that causes the symptoms is epinephrine. The sympathetic hyperarousal that the patients get, the anxiety, the diaphoresis, the tremors, these are all part of the body just trying to get the glucose back to reasonable levels. But if these systems fail at a certain point, the brain simply starts to run out of energy and begins to shut down, causing lethargy and eventually coma and death. So these are kind of a big deal. Fortunately, they don't usually present with decreased CNS functions right off the bat. The sympathetic hyperarousal basically is the warning shot that tells you, yes, you need to give these patients glucose. So you can be sure to normalize the glucose, take them to the OR, and remove that tumor. But wait, hang on just a moment before you get your trocars out. This is going to sound super cynical, but we got to make sure that the person isn't faking it. Why they'd want to fake an insulinoma, I have no idea, but consider that insulinomas are super rare. You know what's not rare? Medical-grade injectable insulin. That stuff is everywhere. It's very easy to give yourself hypoglycemia if you've got factitious disorder or something just by injecting way too much insulin. So how are you going to tell if it's exogenous or endogenous insulin? No, future radiologists, you do not get any imaging. The answer is to check that both the insulin and C-peptide are elevated. Remember C-peptide, that little bit of pro-insulin that's secreted when endogenous insulin is made? Well, it turns out that injectable insulin has no C-peptide in it, so if they're just making themselves sick, they'll have elevated insulin but decreased C-peptide, because their own endogenous synthesis is going to be suppressed by hypoglycemia. Carcinoid syndrome is an interesting one. It's a tumor that originates from neuroendocrine cells, most often in the walls of the small intestine, and it secretes serotonin. Now here's the interesting part. The liver is really, really good at metabolizing serotonin, so much so that a GI carcinoid tumor has absolutely no symptoms, because all the serotonin is portaled straight to the liver, which chews it up and spits it out again. The irony of this whole situation? What's the most likely place for a GI tumor to metastasize to? It's actually the liver. If the carcinoid tumor managed to park itself in the liver and dump serotonin straight into the hepatic venous circulation, the tumor will present with carcinoid syndrome. The circulating serotonin causes a classic triad of asthma, diarrhea, and cutaneous flushing, and it also causes an interesting finding that really has no good pathophysiologic explanation: right heart valvular abnormalities. A lot of patients with carcinoid syndrome will present with odd, otherwise unexplained murmurs. Finally, carcinoid syndrome can cause a B vitamin deficiency, and if you remember which one it is, you get major points in my book. Give up? It's a pretty minor point from biochem, but serotonin is actually synthesized from vitamin B3. So, the synthesis of that much serotonin will lead to overconsumption of vitamin B3, which leads to, potentially, pellagra. Remember the 4 Ds? Diarrhea, dermatitis, dementia, death? If you got this one on your own, by the way, you can call Dr. Tao Li, the editor-in-chief of First Aid, for a personal congratulations at 1-800-555-3253. Most of the time, surgical resection is indicated for this tumor, but these tumors are also responsive to somatostatin, being GI tumors, so the analog octreotide actually works pretty well for symptom suppression. Zollinger-Ellison syndrome, which for whatever reason I always remember as Renée-Zellweger syndrome, is a syndrome caused by G-cell tumors that secrete gastrin, otherwise known as gastrinomas. Now this will take you back to GI, but y'all remember what gastrin does? It's the hormone that's primarily responsible for increasing the synthesis of stomach acid, and I'm sure you can see why too much of this stuff definitely is not a good thing. So what are some of the symptoms? Ulcers is definitely a good answer. In fact, this syndrome causes some of the most heinous ulcers you've ever seen, all the way down to the jejunum. Jejunal ulcers, by the way, are really uncommon in peptic ulcer disease and are a major buzzword for Zollinger-Ellison. If you're scoping the patient, you might also notice hypertrophy of the stomach's rugae, because gastrin causes proliferation of the cells of the stomach. Finally, even the duodenum gets so acidic that it literally inactivates pancreatic enzymes. This leads to severe diarrhea and malabsorption. The test for Zollinger-Ellison syndrome is pretty weird. It's called the secretin stimulation test. Now those of you budding gastroenterologists might be thinking to yourselves, but wait Arjun, doesn't secretin inhibit gastrin secretion? Well, that's usually correct. Secretin is pretty much the antacid hormone of the GI tract, but for some reason nobody can quite figure out, gastrinomas reliably increase their gastric output when hit with a large bolus of secretin. Just something for you to think about. Now you can treat the symptoms of acid hypersecretion with proton pump inhibitors, but since gastrinomas do have malignant potential, you'll probably want to surgerize them eventually. Now that we've covered the endocrine neoplasias of the GI tract, let's try a flash quiz. Alright, this one might take a little bit more noodling than your average flash quiz. What are the first symptoms of hypoglycemia in a patient with an insulinoma who also takes metoprolol for blood pressure? This is a bit tricky, so pause and think before answering this one. So, while the first symptoms of hypoglycemia are normally symptoms of sympathetic hyperarousal, sweating, palpitations, etc., patients with beta blockers never get these symptoms, which makes sense, right? Because many of these sympathetic effects are mediated by beta-adrenergic receptors. And this can get really dangerous because most people at least get a little bit of a panic attack or palpitations that let them know they need to drink some OJ or something. Patients on beta blockers, on the other hand, can pass out or get altered mental status without any warning at all. So the correct answer is CNS symptoms, meaning the symptoms of CNS depression. The multiple endocrine neoplasias, or MENs, are a great example of the difference between clinical medicine and step 1 medicine. They're these esoteric disorders that are zebras in practice but disproportionately high yield on step 1. They're a collection of autosomal dominant disorders like the neurocutaneous disorders, but instead of causing tumors of the nervous system, they predispose individuals towards endocrine tumors. Now, I usually hate memorizing stupid lists, but the first aid mnemonic for these is so good and so memorable that I'm seriously sorry I've never seen a MEN patient on the floors. I'd have killed that diagnosis. Anyway, in the first aid mnemonic there's an acronym and a visual mnemonic for each. Let's start with MEN1. MEN1 is a mutation of the creatively named menin gene, whereas the others are mutations of the RET gene. It predisposes to pituitary tumors, parathyroid tumors, and endocrine pancreas tumors, like the insulinomas, glucagonomas, and gastrinomas you just learned about. So that's 1 M and 3 Ps. If you look at the figure, you'll see that anatomically, these organs form a diamond. MEN2A is characterized by a marfanoid habitus and predisposes the patients to medullary thyroid carcinoma, parathyroid adenomas, and pheochromocytomas. 2 M's and 2 P's. It's getting kind of scary, guys. While MEN1 is the diamond, MEN2A is a square. MEN2B has the marfanoid habitus, mucosal neuromas, which are these benign growths around the mouth and face, medullary thyroid cancer, and pheochromocytomas. 3 M's and 1 P. See, I told you guys, this is the best mnemonic ever. As you can see, there's a lot of overlap with MEN2A, which kind of makes sense as they're both mutations of the same RET gene. But men 2b doesn't form a square, it forms a triangle. So to recap, men 1 the diamond has 1 m and 3 p's, men 2a the square has 2 m's and 2 p's, and men 2b the triangle has 3 m's and 1 p. Brilliant, I know. Now, just like the neurocutaneous disorders, there is highly variable penetrance with the MENs. Just because you have men 1, for example, doesn't mean you're going to get a pituitary and a parathyroid and a pancreatic tumor. You just have a higher risk for those. But probably the most important thing to keep in mind is the familial inheritance. If dad and uncle have a marfanoid habitus and grandpa had a pheo, it may be time to get genetically tested for a RET oncogene mutation. And that concludes endocrine pathology. I hope you enjoyed it, and stay tuned for the pharmacology section. Compared with this lecture, it's a piece of cake, especially considering you're all masters of endocrine physiology at this point. If you think my lectures are insightful and fun rather than eye-gougingly horrible, let me know by giving me a thumbs up down below, and if you're feeling generous, leave a comment. That's all I got for you. Arjun Iyer, signing out.